So yes, why other challenges matters to us, because there are a lot of uh, clear inpatient glucose targets which have been already proposed. Basal bolus insulin protocols have been discussed, ICU versus non-ICU recommendations, and the prevalence in India, which has shown about the data of Indian prevalence of 20 to 56, and stress hyperglycemia is around 20% in ICU patients. So what we are discussing or we want to discuss is on that we need to move beyond glucose targets and highlight system gaps, what we are discussing today, recognize heterogeneity in hospital population and bridging the attention transition patients who are on steroids, CKD status, technology, and the discharge, what we are discussing on. So focus is to shift from glucose control to whom, when, and in what context to be given here. So the first one would be like the vulnerable population, frailty, and the end of life here. The previous document has mentioned that general inpatient targets hypoglycemia as avoidance, stress, and no structured frailty based target modification was given here. We suggest that suggesting that stringent targets in frailty and limited life expectancy, where we need to emphasize that simplified regimen should be given and reduce SMBG frequency for the patients, as well as the comfort focused care in end of the life here. So should we put this fragility assessment be mandatory for all of us? Yeah, when we are discussing on this assessment. So age alone should not be decided targeting, but patient's context is also to be seen here. Then the CKD and dialysis, the insulin dose reduction in low GFR and general CKD precautions for already been put up. We are here to discuss on the uh, matter of HbA1c unreliability in advanced CKD status, and dialysis day insulin timing, post dialysis hypoglycemia, which is usually seen. So dialysis is seen over after that lot of hypoglycemia events or hyperglycemic events when insulins are discontinued here or it's been tapered or adjusted dosages. So dialysis should be seen as a glycemic reset event. Then comes the steroids, nutrition, and abrupt stops. So, steroid induced hyperglycemia, we have already spoken and we know that about it. So, basal bolus recommendation and TPN insulin caution is already been mentioned. Uh, Today, the meat is allowed about the match insulin to steroid pharmacokinetics. So, if the patient is on prednisolone, we can offer NPH. Dexamethasone, we can go for a basal analog, and once again insulin continuation during the steroid tapering here. So we can also put down about the warning, strong warnings that no long acting insulin when TPN is given, and once it is stopped, it is like an worrisome, or we can take it as an alarm to take control of the sugars and monitor it stringently. Then is about technology, pumps, and competence gap. I guess CGM, we have already spoken a lot on that, but training the staff is very important, because if it is not planned, then it is going to be a failure, and we need to highlight that alarm fatigue, data overload, and competence gap here. And the last, I would like to take a note of this discharge. We have already spoken about this, but when the patient is discharged, there are no fixed protocols, or we don't know when the patient is supposed to be coming to the clinic or take the follow up. We just ask them to come back, and when we don't know. So we need to put it across that tele follow ups within 7 to 10 days after the discharge is supposed to be very important here. So thank you so much. I'm not going much more.